Assalamu alaikum. Masha al-khair. Good evening, everybody. Welcome to the second episode of the Combined ENT Masterclass. This is a CME program developed by the Better Hearing Society in Egypt through what's known as Learn Program for CME. In the beginning, I'd like to thank the sponsoring companies and the organizing company. We had last week the first episode, and I also would like to thank all the attendees who shared with us the last week 2 sessions in the first webinar. Tonight, I also promise you will find a very interesting 2 topics by renowned speakers from Egypt and UK and Saudi Arabia. And I'm sure it's going to be a very nice evening with a very rich discussions. The first hour will be Dr. Ali Mahrous, so he's the head of ENT department at Al-Azhar University, who will debate about the Otitis Media with Effusion, which is, I'm sure it's a common ENT problem. And all the attendees would like to learn and to listen to distinguished speakers, what they are really doing in their practice, not only what is written in the books, but also what they are really doing in their practice. I don't want to take much time, so Dr. Ali Mahrous, please come on and go ahead and proceed with the first webinar. Dr. Ali.
Hello, good evening, everyone. First of all, I would like to thank Professor Essam Abdulhamid for his kind invitation to moderate this panel discussion titled Otitis Media with Effusion. My thanks extend to our distinguished panelists tonight, who both happened to be from our beloved medical school, Alexandria, and they both happen to have a vast Western experience in the field of otology and lateral scalpel surgery, and they both happen to be working abroad as we speak. So I would like to welcome Professor Essam Saleh. He is the head of ORL department in King Abdullah Medical City in Mecca, and he is the director of the CI program in the same medical city. Equally important is to thank my sincere friend from the UK, Professor Eslam Osman. He is currently a consultant otologist in Entry Hospital in Liverpool. So welcome both of you. And using the panel discussion tonight, the objective of this is to really, as Professor Osama Hamid pointed out, is to talk about the otitis media with effusion from the clinical perspective. So otitis media with effusion is a very common clinical condition that we encounter on a daily basis. And it has acquired so many names over the years, as you can see on the screen over there, starting from secretory otitis to serous otitis to non-purulent otitis media to catarrhal otitis. But the scientific body of opinion has settled to call it otitis media with effusion, which I'm going to abbreviate throughout this panel by OME. So the first question tonight is for Professor Essam Saleh. What advantage do you think that the current nomenclature for this, as in OME, over the previous names for this condition, Professor Saleh?
Well, I think the otitis media with effusion is the proper terminology for this condition because it more or less delineates the pathogenesis of the condition. It is an inflammatory condition. It's not an infection. It's an inflammatory condition which occurs in the cells of the secretory cells of the middle ear and eustachian tube, and this will cause the effusion. So it's not a secretion actually, and it's not, it's more or less not a serous otitis media, not a catarrhal, not whatever. It's better terminology, it's better delineates the pathology of the condition or the pathogenesis.
Right, so essentially because it's what was found, because it's actually exudate rather than transudate, and
Yeah.
that indicates being inflammatory or active inflammatory process rather than a passive extracellular filtration of fluid. So there is an arbitrary definition for otitis media or effusion, which is they call it chronic otitis media or effusion when the symptoms persist for 3 months or more. And we all know that actually the limit of 3 months is an arbitrary clinical judgment and is not the histopathological definition of being chronic, where you would see chronic inflammatory cells. Now, the question is, Professor Eslam Osman, how strict would you be in applying this 3-month limit to define OME being chronic, and you apply it in your practice? Islam.
Thank you, Dr. Ali. My practice is mainly adult practice, and I'm not really, strictly speaking, limit myself to the 3 months, because if I have a person who works as a telephonist, for instance, and he is not able to do his job because he can't hear the telephone, I would not stick to the 3 months. Okay, right. Because I need to help this fellow. He's not able to do his job. And all my patients are referred from the GP. So you usually have a period of watchful waiting by the GP. So when they come to me, they already had waited sometimes to get the appointment in the clinic.
Great. I think that's very important, actually, is to adopt this holistic approach to our patients and get the best interest for the patient rather than keeping to the one period of time, which is 3 months. So we know that OME has multifactorial etiology, including immunological, anatomical, pathological considerations, in addition to the environmental, socioeconomic, gait, genetics, bottle feeding, smoking parents, allergies, and nasal issues. So many factors that pave the way for the infection to happen. And there are special categories, which I'm going to talk about them later on, like cleft palate Down syndrome, etc. But the question here is to Professor Eslam Osman. Is the adenoids has always been incriminated as a causing agent for otitis media or effusion. How would you see the relationship between adenoids and OME?
Again, in my practice, I see a lot of cases with otitis media with effusion in adult people who don't actually have adenoid at all. If you examine the postnasal space, is clear. In children, right. Yes, you have the otitis media with effusion more commonly in children with adenoid. So not necessarily that every patient with otitis media with effusion will have an adenoid or enlarged adenoid.
Right. Let me put this question in a different way to Professor Essam Saleh. Now, would you see the relationship between adenoids and OME as in association, such as smoking and lung cancer, for example, or would you see the relationship as in cause-effect relationship, Professor Saleh?
I do believe there is some causal relation effect, especially when the adenoid is large, not exactly large, but also closing the torus tuberous. It's the where the adenoid is large, exactly, is it causing a closure of the eustachian tube orifice or not? Or another thing is some adenoids might have what we call a biofilm of bacteria, which really precipitates to the occurrence of recurrent otitis media and also to otitis media effusion. So usually if the adenoid is not very large, especially in young children, we do not really, and it's not indicated per se for surgery, we don't do it.
Right, okay.
If, yeah.
Well, yeah, I think the evidence is far away from being cause-effect relationship. I think there is probably an association between adenoids and OME, but it's never been cause-effect relationship, as we will see later on the indication of adenoidectomy in cases of OME. Gerd, Professor Saleh, any relationship in your practice? Have you ever given a child PPI or anti-acid for? So really the evidence is not really that strong to, but there is some research that would suggest a relation.
I think it's just association.
Right, great. Now we'll come to the pathogenesis of OME, and it all stems from the eustachian tube dysfunction. And the commonest that we see in our clinical practice is actually the dilatory eustachian tube dysfunction, rather than being challenge-induced or patulous eustachian tube. We see them sometimes, but this is not actually the domain of our talk tonight. The dilatory dysfunction of eustachian tube could be mechanical obstruction or could be an anatomical defect, such as in cases of cleft palate. Now, in terms of diagnosing the condition in question, there is a fair percentage of children actually asymptomatic. And that is the lurking danger of otitis media or the effusion. Because some of these children, particularly in young age, where there is the peak of neural plasticity, and this would have an impact on their central auditory processing. How much weight, Professor Eslam, would you apply to this condition in relation to central auditory processing disorder?
I think there is a growing evidence to say that there is a strong relation between the development of the neural tissues in the brain with the ability to hear from the child. So if a child is not able to hear, I think he will have a sensory processing problem during his development. So it is very important for the child in the growing age to be able to hear, so the central connections develop as well.
Thank you for this. I think that's very important. It's a really an important message for the young generation of doctors, that although this is a very common condition and it usually resolves on its own, but it can be serious. And I think that is a message that we would like to really put out tonight, out of the panel discussion. The children may present with inattentiveness, lack of school progress, and hyperactivity or delayed language development. And I think that is something that we should also take in mind. Now, in terms of examining their ease, commonly what we see is actually dull, opaque tympanic membrane losing its luster. You see some air bubbles in there. But in exams, it's kind of a tradition in Egypt that if the candidate has not mentioned the cone of light, they may not pass in their exams. So the question now is for Professor Eslam Osman, how much weight would you give to the cone of light in confirming the diagnosis of OME?
I have to be honest, I don't really look for the cone of light. I look to the whole of the tympanic membrane. And all my cases get examined because they are adults. They get examined in the clinic with the microscope. And surprisingly, even with a normal tympanogram, you can still see fluids behind the eardrum, which is not filling the whole middle ear space. So the most important part of the examination is your clinical examination and with the microscope rather than the otoscope.
Right. Any different opinion, Professor Essam?
I really don't think the cone of light has that importance that was given to it. I don't depend on it at all.
And that is the whole point of actually, making this point, is that we must not rely on this. And I think there's much more weight given to it in our exams for the cone of light. Now, the next question is for Professor Essam. pneumatic otoscopy versus tympanometry. Which one would you adopt in your clinical practice and why?
Okay, pneumatic otoscopy needs a little bit of skill, so it should be done by a skilled otologist. I use it a lot, definitely. And it is a very good tool, I think, in diagnosis.
Is it an alternative to tympanometry?
The problem is you need something objective for medical legal purposes sometimes to document that this child or this person has otitis media with effusion. And this is only available with tympanometry.
Eslam, do you have a similar or a different opinion?
I have to be honest, I don't actually have a pneumatic otoscopy in my trolley of instruments. We don't have it in the UK, we don't use it.
Right.
So we rely on the tympanometry.
Great. Well, the reason I'm raising this point is actually the American Academy guidelines in 2015 has actually put a lot of weight to pneumatic otoscopy to the extent that it actually mentioned that pneumatic otoscopy should be used as the primary diagnostic method for OME in a child with otalgia or both. Tympanometry should be obtained if the diagnosis is uncertain. So as if that we should use pneumatic otoscopy first, all of us. But in fact, actually, I don't have it in my clinic as well. So we seem to have probably similar opinion or similar experience in using tympanometry as probably an objective method of confirming the diagnosis of otitis media with effusion. Now, for the hearing test, Eslam, if you have an adult patient coming to you with bilateral OME and you request an audiometry for this patient, and the audiometry comes back showing an airborne gap of 40 decibel or more, how would you interpret this?
Actually, the interpretation depends on the hearing requirement of the patient himself. So the job, the kind of job the patient is doing. So if he is a manager or is he a manual worker, what would he need? So 40 dB, I think this is significant hearing loss, especially if it is bilateral, then I would be more inclined to offer the patient either ventilation tubes or hearing aids.
But let me put this question in a different way. Do you think that the effusion per se would lead to a 45 decibel hearing loss?
It depends on the thickness of the effusion itself. If it is a mycoid effusion, very thick, yes, it can cause. Yeah.
So you think that if it is too thick, it can
yes.
lead to that
Definitely.
level of hearing loss? Professor Saleh, do you have a different opinion?
I had very few cases that had really kind of 40 decibel or 45 airborne gap that were pure effusion. But still, whenever I find the airborne gap is that much, I always put in mind that there might be something else. I think
yes.
kind of a sacral problem, adhesions, whatever other pathology, I put in mind before, and I tell the patient that probably we might be needing something else.
So probably I would reverse the question back to Eslam here. In the UK, Eslam, if you get this like 45 decibel, would you not inform the patient that there may be some ossicular issues here if you plan to go ahead with ventilation tube insertion?
When we offer the patient surgery, we tell them there is no guarantee that you will improve after the operation. So you might improve, you might not. If he doesn't improve, then we'll have to look to something else causing this hearing loss after draining the fluid and putting the ventilation tube.
Fantastic, great, thank you. It's a very pertinent question, and the reason I'm asking it actually is that I have seen lots of young generations of doctors who would request a plain X-ray soft tissue nasopharynx for the children with a diagnosis of OMEs for them to check the size of adenoids. Would you recommend this, Professor Saleh?
Actually, I very rarely do X-ray in nasopharynx now, especially in children. We don't really want them to expose to radiation. I use the scope to ascertain if there is any adenoid or not. And children, it seems difficult, but really, if you can use the fiber optic or even the 70 scope from the mouse, and you can get a good evidence of is there an enlarged adenoid or not.
Well, I think the evidence is against requesting any X-ray for these kids, and I think this is really exposure to an unnecessary radiation. True. And it's not going to change the line of management. So, true, as you can see there on the screen. So now, in terms of unilaterality of effusion, I think that's very important to consider, particularly in adults, obviously, to consider the serious pathology in the nasopharynx, congenital cholesteatoma. Sometimes the CSF autourea can lead to unilateral effusion, particularly in the presence of history of head trauma and what have you. The question is, how many times in your clinical lifetime, Professor Saleh, have you seen a CSF leading to unilateral effusion?
At least 5 times. One of them was even bilateral, and she came to me after putting a grommet tube elsewhere. And what came out was a CSF. Actually, 3 cases came like this, and they were pure CSF.
Right.
Can I ask a question?
Yeah.
The 3 cases were bilateral, Dr. Essam, or only one?
No, one of them was unilateral and 2 others were bilateral. They had benign intracranial hypertension. They were adults, of course, and they were having benign intracranial hypertension that caused the spontaneous CSF autourea.
Right, right. So I think it is very important to take this into account, that unilaterality of any paired organ should be considered as a sign of maybe serious underlying pathology until proved otherwise. So now, this is a real clinical scenario. This is usually an adult patient, and I have seen this probably 4 or 5 times in my life. Patients come with bilateral retracted tympanic membrane, but the tympanic membrane is quite thick, Eslam, and you cannot really see the ossicles from behind. And you do the tympanometry, and it shows type B tympanogram. And these patients would be listed for ventilation tube insertion. You go in and you start using your whatever, myringotomy knife or whatever, or needle, and the tympanic membrane is stuck to the promontory, and there is no space for you to insert any ventilation tube in there. First of all, have you seen a similar case, Eslam, like this?
Definitely, yes, definitely.
What have you done? What would you have done?
I try to insert the tube to try to, in these cases, there is usually no fluid, but the aim of the tympanic, the aim of the operation will be to reventilate this middle ear, hoping that the, you stop further retraction and atelectasis and attic retraction pocket. So I will try my best to put a grommet tube. However, most of them, they usually get extruded quickly.
Would you then offer them a hearing aid?
Yes.
Right. Professor Essam, do you have a similar experience, different experience?
Yeah, but I think the tympanic membrane of being thick, this is very infrequent in atelectasis or adhesive otitis. Usually it's very thin, and you can really know that it's adherent to the promontory. One issue if I find that this is atelectatic, if there are adhesions, which you can try to do Valsalva, sometimes it helps, or if the drum will inflate.
Is asleep, unless you mean under local anesthesia. Yes, yeah.
Yeah.
Okay.
No, I mean even in the examination.
Right.
So if there are adhesions, I doubt a little bit that the ventilation will help, because the adhesions will not allow any ventilation to occur, and you think of other alternatives, I think.
Yes, yes. Probably I would add my this to because in the cases that I encountered, there was no way that one can put any tube in, and the tympanic membrane was actually quite adherent to the promontory or the medial wall of the middle ear, and there was no slot to insert any tube in there. But I think that is educational, that one would keep this in the differential diagnosis. Not every patient coming with flat tympanogram means secretory that you can actually go in. I think the advice here is to examine these patients under the microscope, under a good magnification, and that what probably distinguish both. And as Prof. Essam said, ask these patients to Valsalvas, and I think this may help in seeing whether the tympanic membrane is mobile or not. Now, we'll come to the lines of management of this condition in question. I think the 3 lines of management that are recognized worldwide: watchful waiting, surgery, and the last is the non-surgical treatment. As you can see, there's lots of question marks I'm putting in on the screen. But let us talk about the watchful waiting first. As we know, the natural history of OME is to resolve on its own without any medication. That is the natural history in the majority of cases. That's why we adopt the watchful waiting policy, and all the guidelines all over the world is actually suggestive of doing this. But the question is to Eslam here, when would you not wait and see? I know, Eslam, that you deal with adults, and I think that's a bit of a trick tonight, because the primary scope here is about children. But obviously you were practicing before in children, I know that, but when would you not wait and see in the children?
If the child language development,
Right,
the school performance is not up to the standard, then I will try to interfere as soon as I can.
Right. Professor Essam, would you like to add?
I think if I find in special cases like cleft palate or like Down syndrome, I mean, these cases, they do have what I call it's a deficit or a problem in the eustachian tube function, which will not improve.
Right.
So I don't really find the recommendation of the guidelines to wait here really very wise, because the majority will not.
I think the guidelines are meant for the mainstream cases, not the special cases.
They mentioned that in special cases, after 3 months, you have to interfere. I don't approve this, really.
Right. Well, I think I would add to what you've kindly mentioned, both of you, is that the structurally changes to the tympanic membrane is very important. So if I see the tympanic membrane, that's really collapsing and plastered to the ossicles, I would probably not wait, because I know that this is being long-standing effusion there.
Definitely,
so,
I agree.
So the first line of management is the surgery. Now, we can talk about surgery for ages, but I think if we talk about it within the context of the mainstream cases, would you start with the grommets, as in shepherd or shark grommets, or would you start with the T-tube, Eslam?
I start with a grommet.
Right.
And then the T-tube is either in the second, if the case recur, second time, or even the first time. But I usually start with a grommet.
When would you start with the T-tube straight? Are there any situations where you would put a T-tube straight?
Obviously, if, like Dr. Essam said, if a child with a cleft palate or something which is a long-standing problem, then I may offer the patient T-tubes, but they have to understand that the complication of the T-tube is more than the complication with grommets.
Yes, that's right. Now, I'm actually coming back to the adenoids issue. We've discussed it earlier in terms of the etiology, but we're discussing here within the context of management. Now, the indication of adenoidectomy in the context of OME, what are they, Professor Saleh, in your experience?
Well, if the adenoid is enlarged, definitely, I mean, it's indication for adenoid per se, we will do it, definitely.
Right.
If it's enlarged, causing obstructive sleep apnea or whatever. But if the adenoid is not large enough, I mean, it's a grade A, a grade 1 adenoid or something, and this is the first time the child is doing, and he's young, I mean, young is less than 3 years or something, then I will not do the adenoidectomy at this age.
So you take the age into account?
I take the age into account, yes.
I think that's very good because the American guidelines in 2015, it actually made a clear distinction in terms of age for adenoidectomy, where it actually said below the age of 4, just tympanostomy tube, but after the age of 4, it's ventilation tube and or adenoidectomy. And I think that is something that we should actually take into account, because when these guidelines were devised, it was actually to calculate the benefits versus the risks. And it was found that below the age of 4, the risks outweigh the benefits of adenoidectomy, unless it's obstructing, causing obstructive sleep apnea. So that is something that we should all take into account. Now, tuboplasty, Eslam, would you use it, would you apply it in your adult patients in the UK?
Personally, I have no experience in using the balloon tuboplasty, so I haven't used it before.
Right. Professor Saleh, have you used it?
Well, unfortunately, I haven't used it. I'm trying to get it because I have attended a lot of, talks about and some studies that were controlled studies claiming a very good benefit in balloonistation tuboplasty. However, all these studies, the benefit was for some time. It was temporary. After a couple of years, it comes back again. We have to put in consideration the cost. It's very costly.
Yes, particularly in developing countries. Yes,
of course. Yeah,
I do agree. Great. So now let us come to this very controversial issue: the non-surgical treatment of OMEs. And I know there is quite a lot of doctors, particularly in Egypt, actually. They use antibiotics. Some use systemic steroids, decongestants, Otovent, and carbocysteine. What do you think, Professor Saleh, about this? Would you use these medications?
Before, of course, maybe kind of 20 years ago, I used some of them, but now I no longer use these. I think they have no benefit, except if the patient is allergic, definite allergy, nasal allergy, I give steroid sprays. That's the only thing I would give. The Otovent is controversial. I used it sometime, but I'm not so convinced of the efficacy. Especially, it's difficult for children to use it, so I no longer use it.
Eslam?
I have guided by the NICE guidelines, so I can't really use any of those treatments that you mentioned, except the Otovent, which there is some evidence that it works and it has no harm. However, I cannot use antibiotics, steroids, decongestants, or carbocysteine. I can't.
Right. Okay. Well, let me give you this surprise, actually. Carbocysteine was strongly recommended by the Japanese Society, the guidelines for Japanese Society in 2017. And that was actually based on very good, well-conducted studies in Japan of the role of mucolytics, basically, in otitis media or effusion. Having said that, I looked up the American guidelines, which mentioned nothing about cysteine. And that is kind of divide between the East and West in this. But the Japanese use carbocysteine all the time in otitis media with effusion. So both of you have no experience in mucolytics or any research done on this? No? Okay. Well, but that shows actually probably because of the strong recommendation by the Japanese Society, we may actually think of conducting some research on this to find out. The cleft palate, Eslam, would you deal with it differently from the rest of, in comparison to other patients with cleft palate?
Yes, I will be inclined to push the patients towards the hearing aids rather than the long-term ventilation, taking in consideration that it's a long-term problem, and he might have problem with the T-tubes, reinsertion of T-tubes, too many anesthetics. So I'll be more inclined to push the patient towards the hearing.
But if you do so, then you still have the problem of the sequelae of OMEs. The tympanic membrane would be atelectatic, and you know, you may end up having cholesteatoma.
I agree with you, but putting the T-tube will not stop the sequelae. There is no evidence that putting the T-tubes many times will stop the cholesteatoma.
So putting the T-tube is not going to help the ventilation of the E?
It will help, but what I mean on the long run. So I mean when the child becomes an adult,
so
it still has the cholesterol.
How about the adenoids, Eslam?
Again, it will be problematic because of the nasal regurgitation. So
I think it's contraindicated to do adenoidectomy in these. Professor Essam, do you have a different opinion?
Well, I actually do put T-tubes in these cases. I know that in cohort longitudinal studies, they don't really give, they don't help actually, as Eslam said, but I do put them in these cases.
Right. Okay. And adenoidectomy is contraindicated.
Contraindicated, definitely. Yeah. Adenoidectomy cannot do it.
There are some reports talking about endoscopic superior adenoidectomy, or that kind of really kind of fashionable practice. I'm not sure about the validity of these, but I know that there are reports in literature talking about leaving the central pad of adenoids so that it would actually keep the ridge of Passava and the whole kind of velopharyngeal sphincter as it is. But personally, I probably would not take the adenoids out. So Down syndrome children, any experience with these in terms of OMEs?
Oh, yeah. Well, they have, again, eustachian tube dysfunction. That's one. They do have some stenotic ears. It's a little bit difficult sometimes to examine them, even to see the drum exactly. You have a lot of debris. It's difficult to clean them also. Besides, they might do have adenoids, some of them. And a very important issue is they might have other hearing loss other than otitis media effusion. They might have sensory neural hearing loss, and which we have to screen for.
Right.
So these are important things.
Great. Eslam, do you have any?
Yes, as a surgery, I used to find it very difficult to perform insert a grommet in a child with a Down syndrome. The ear canal is usually very narrow. And like Professor Essam said, it's not only the sensory neural hearing loss, but they can have a conductive hearing loss as well in addition. So I would be more inclined again towards the hearing aid in this particular group of patients.
So you prefer to use the hearing aid in these kids because of narrow ear canal, persistence of effusion, and having
other factors,
kind of other hearing loss or mixed hearing loss, so to speak.
I think endoscopy sometimes can help. I mean, if you put a pediatric endoscope, especially if the ear canal is very narrow, you can manage to put a tube in these cases. It's difficult, but with the microscope, it's sometimes it's very difficult that you cannot really do it. I think using endoscopy facilitates things. If you put a 2.7 endoscope, might help.
That's right. I think the evidence is it's going to be really difficult surgery-wise because of the very narrow ear canals, and I remember once actually I had to get this French grommet tube, which is the smallest one, and I couldn't even push it through the ear canal. So I think hearing aid probably is the best option for these kids. Water precautions. As you both know, that some surgeons would advocate no swimming until the grommet comes out. Would you agree or disagree, Islam?
I will disagree. I allow my patients to go swimming. However, I advise them to use either earplugs or cotton wool with Vaseline in the ears. So no, I don't stop them from going to swimming. However, I don't usually allow them to go swimming freely without anything in their ears either, because that is the commonest complaint I have. People go for a holiday in Spain or whatever, and they develop an ear infection after going into the swimming pool.
But this Cochrane review, Islam, contradicts what you say.
I agree.
I'm sorry, but that's Cochrane.
Yes, yeah, I know.
In 2016, actually, it said even if they don't use any earplugs or cotton wool or whatever, it would not make any difference to the rate of developing post-grommets infection. Professor Saleh, do you have any additional?
Well, in actual practice, I think I have seen a lot of infections after going to, as Islam said. But I know the Cochrane, but I really ask them to put something in the ear. That's what I do. I know the evidence says no, but real life is different.
Right, great. Now, before I conclude, I'd like to ask you a question, both of you, in relation to the current situation, COVID-19, within the context of OMEs as well. If you have an adult, like in Islam's practice, or yourself, Professor Saleh, coming to you with OMEs, and they really bothered with it, and they can't really function, and they push you to operate on them within this current climate of COVID-19. What kind of, well, first of all, would you agree to operate on them or not? And if you do agree, what kind of precautions that your institution is actually applying to deal with patients in this current climate?
There is a growing evidence that people who develop COVID-19 in the perioperative period have a high rate of mortality from the illness. It's up to 20%. So in our hospital, we stopped doing any routine surgery due to this coming evidence that if you develop COVID-19 in the perioperative period, either during surgery, before or after, the mortality rate is up to 20%.
So basically, your concern is about the patient?
Yes. So I don't offer any routine surgery during this COVID-19 pandemic.
Right. So in cases of emergency, in Liverpool, for example, I know that you may not be that really involved in this, but maybe your colleagues in here.
No, I am involved.
Yeah, I'm sorry. Yeah. Okay. So in emergency, what would you do?
If I have somebody with epistaxis who needs volatile artery ligation, we have to do it. Emergency is emergency.
Yeah,
and
but what
urgent cases, cancer cases, yes, they are getting treated. But what I'm saying is, for example, mastoid surgery.
Right.
Do mastoid surgery.
Right, I see. So you don't really take like a PCR from these patients. You just deal with them as it comes, and you take no precautions.
We do PCR for the patients who are having surgery, but only urgent cases. So we do ask the patient to isolate themselves for 14 days before surgery, and then they get PCR 2 days before the operation, and then they have the surgery. But only urgent cases.
Right.
It's the same in our
hospital. Yes. Any different?
In our hospital, it's the same. Yes, we don't do any elective cases now. We do only urgent cases, and we don't ask isolation for 14 days, but we do COVID 2 days before. Either the patient isolates at home. This is something not the guidelines of the hospital. The hospital says the patient should be admitted and do the PCR, and after 2 days, the result comes, and if he's negative, then he goes to the OR.
But how about if the patient comes to you, Professor Saleh, with a stridor, and you'd like to do...
Okay, you will consider, you will consider that he is COVID positive, whatever it is. You will take the full PPE precautions.
Right. Yeah.
I have to do it, of course.
Great. That is great. Well, I'd like to conclude by these salient points that the otitis media or diffusion, I would like to call it the silent enemy, so to speak, because some of these kids are asymptomatic. And if we don't have the high index of suspicion, we may deprive them from the central auditory processing. And these patients can be for the rest of their lives if we don't deal with it promptly and on time. Our approach to OME should be like a jigsaw puzzle approach or the holistic approach, not just 3 months or 2 months or 4 months. It's actually the whole patient as a whole, as a one unit, to consider all the variables and factors that our respectable panelist has talked about tonight. But the surgery remains the primary modality of treatment. And I think we should avoid overdoing adenoidectomy. And we must not take unilateral effusion lightly. By this, I would like to end by thanking my sincere friends, the distinguished panelists tonight, who have really added a lot to this discussion. Thank you for your time.
Thank you.
Thank you, the audience, for your time as well. And I have thoroughly enjoyed this panel discussion with you.
Thank you very much.
I will see you another time. Thank you.
Dr. Ali, thank you very much for moderating this very important topic, if I would say. And also, I'd like to thank Dr. Essam and Dr. Eslam for joining us and enriching the discussion. Actually, we had one question that I really think is also, it's a real situation question. And Dr. Ahmed Yunus is asking about a patient with known eustachian tube dysfunction. His left ear shows perforation and also absent incus and eroded malleus. And so he decided to do tymparoplasty with PORP and cartilage graft. And he is asking, does he have to do a T-tube at the same time during surgery or not? So I'd like to hear from Dr. Ali, Dr. Essam, and Dr. Eslam about answer this question. Dr. Ali?
Well, with these patients, I would like to know about the status of the contralateral ear. And if the contralateral ear looks normal, I would not put any T-tube or a ventilation tube in this. But if the contralateral ear is showing eustachian tube dysfunction, particularly atelectatic or adhesive, then I would probably put a grommet tube and not a T-tube. It's like a short-term ventilation tube. That's my answer.
Dr. Essam?
I think the same, because if it's a unilateral condition, I don't think that he has a problem. It's not unlikely that he will have a major eustachian tube problem. And by this, you will just do the surgery and it's all. But if the other condition, if the other ear is atelectatic or has adhesive otitis media and it denotes eustachian dysfunction, then we would put a grommet together with the surgery. And again, I will not put a T-tube.
Dr. Eslam?
I wouldn't put the T-tube or the grommet tube on the first surgery. So I will graft the eardrum, make sure that the eardrum has healed. If the patient develop at a later date either effusion or atelectasis, then I might use the grommet or a T-tube.
Okay. Dr. Wissam, do you have any other questions from the participants? Dr. Wissam from the organizing. Dr. Ali, you can go to the question and answer. You can see if there is any questions, Dr. Ali.
For the participants, okay.
Yeah. Do you have any questions there?
Let me see.
Okay, until we get that, I have another question, because you know the pediatricians they are interested to see the middle ear and if there is fluid in the middle or not. They use reflectometry. What is the experience of the panelists about the reflectometry? Are you using it, or are you familiar with it? What's your experience, Dr. Ali?
سوري يا دكتور أسامة، معلش أنا كنت بدور على الأسئلة. أنت حضرتك بتسأل إيه دلوقتي؟
Reflectometry. It's something like an ultrasound.
Yeah,
kind,
this is called, this is actually sonotubometry.
Yeah,
that's the term there. Well, it's one of those things that have been, you know, the eustachian tube is probably one of the most extensively investigated in the field of otology. But none of these tests has really proved that it's comprehensive. You know, the specificity and sensitivity of any test on the eustachian tube is not that high, and that's my experience with it. So
you know, it's used more by the pediatricians to help them to access the ear and get some information. So we know that it's not very sensitive, but it helps the pediatricians. So and then they may refer the patient to ENT for further evaluation. Well, what do you think about its use in the pediatric clinics?
I have no experience, so I can't really answer this question.
Some and Dr. Islam,
again, I don't have any experience.
No, we don't use it in the UK.
I think there's a question from Ibrahim Abdelal here. What is the role of surfactant in Otitis Media with Effusion?
I don't use it.
Probably not. I have not used it. No. See, there's a question from Professor Yusuf Saleh. How to rule out middle ear effusion in a type B tympanogram with the presence of myringosclerosis? That's a question to Professor Essam Saleh.
This is a very difficult issue. I mean, I have personally faced this with the case that I did a shield graft using cartilage. And so you cannot really know what's behind. It's a very difficult thing. I think the only way is to do a CT scan and see. CT scan will tell you if there is some soft tissue, you know, mass in the ear or not. Probably it's an effusion, probably not. But otherwise, you cannot know for sure.
Dr. Islam?
I will examine the patient under the microscope. I may be able to tell if there is fluid or not, but most of the situation, it is very difficult.
Well, I totally agree, but I think in my experience, if it is only myringosclerosis, it doesn't really impair the hearing that much. The hearing is going to be impaired if there is tympanosclerosis, which would actually hinder the ossicular movement. But that is all what I say about this.
But you cannot know this unless you open the ear, I mean, because it can be a myringosclerosis with a tympanosclerosis at the same time.
Yes, that's right, that's right. There's a question from Abdurrahman Muhammad is saying, patient 12 years old presented with atelectatic both ears with a small perforation in the right side, not affecting the hearing, nasal allergy, hypertrophied turbinate, atelectatic left ear improved with medical treatment, partial tympanoectomy is done, improved the right ear. What are your opinion about the case, especially in the right ear? Well, there's a perforation and the hearing is normal on the right, so there's nothing to be done, my understanding. So the question is normal hearing on the right, but there is a small perforation, and the question is what to be done about the right ear? Well, probably nothing for me because the hearing is normal. Unless the panelists have a different opinion.
But just a follow-up, a close follow-up, because if it develops into, if it's retracted, it might develop later into a cholesteatoma, then you have to check
There's
it out.
another question from Professor Yusuf Saleh. Do you use tympanostomy tube for attic retraction?
No.
No. No. So the answer is no from the three panelists, including Professor Essam Abdel Hamid as well.
There is another question that you did a meningotomy and tube application, and in the follow-up, you like say 3 months or whatever after the operation, you find that the tube has fallen inside the ear and the drum membrane is intact. So it is in the middle ear, and actually the patient is fine. And there is no symptoms, and still there is like 10 dB hearing loss. What do? You remove the tube or you keep it and follow up?
I personally, I will keep it and follow up. And if the patient
Okay.
I'll keep it and follow up. I think it's because the material of the tube is like a pore torch. It's the same.
Yes, yes. Ali, you have a different opinion?
Well, if that, no, not different really. It depends on where you practice. But if this patient is from the vicinity where I practice, and I can see this patient whenever the parents are concerned about this patient, then I would probably keep an eye. I would do exactly like the others. But if this patient is coming from a very remote area, anxious parents, and they really worried about their kid, and they know there is a foreign body in the Middle East, I would probably alleviate their worry and take it out, not because of the harm that is going to cause, but actually, as I said, to put this family at a bit of worry. Yeah.
That's your point. I think. All right. I think we have come to the end of this session, the 1 hour. Again, thank you very much, Dr. Ali, Dr. Essam, and Dr. Eslam. It was a very rich discussion. And I'm sure a lot of people who are attending with us have benefited a lot from these real situation discussion. Thank you very much.
Thank you.
And now I'm also very delighted to introduce Dr. Yasser Khafagi. He is the head of the ENT department at Mansoura University, to moderate the second session about the allergic rhinitis. Before we go, I have one announcement I'd like to share with with all of you speakers and also with the attendees, and I'm going to repeat it in Arabic as well. We at the Learner program, we've decided that those attendees who have attended the three episodes, the last week, this week, and inshallah the next week, we're gonna give them an electronic certificate of attendance of this CME activity. And those of you who are interested to have it accredited from the British Academy of Continuous Medical Education, please contact the Global Event Planner Company, one of the 2 organizing companies, so you can reach them and you can have a stamped accredited certificate from the British Academy of CME. You may have to pay a little bit of money to get this CME accreditation from British Academy. بنقول announcement اعلان للساده الزملاء اللي حاضرين وابنائنا اللي حاضرين على الويبينار، انه اللي حضر الويبينار اللي فات الخميس الماضي والنهارده والخميس الجاي، طبعا انتوا عارفين ان الزوم ابلكيشن بيقدر يخلينا نعرف حضر امتى وقد ايه، فنقدر نديكم، هنبعت لكم فري اوف تشارج بدون اي تكاليف CME الكترونيك سيرتيفيكت، حضراتكم هتطبعها وتحتفظ بيها في يور فيوتشر دوكيومنتس عشان لو عاوز تقدمها لاي جهه ان انت حضرت ده CME اكتيفيتي. اللي منكم عاوز ياخد عليها اكريديتيشن اعتماد من الزماله البريطانيه بريتش اكاديمي في CME يتصل بشركه جلوبال ايفنت بلانر عشان ناخد الشهاده دي، ويبقى يمكن يكون في مصاريف اضافيه على هذا الحكايه. ارجو ان ده يكون خطوه جديده عشان نعتمد الفيرتشوال ويبينارز، يبقى احنا بنستفيد معلومات وفي نفس الوقت بناخد شهاده معتمده تفيدنا في بقى الترقيات وما الى هذا. Thank you very much everybody, and now we'll invite Dr. Yasser Khafagi, and I'm sure we're gonna enjoy a very rich discussion again with this very important topic. Dr. Yasser, اتفضل.
Assalamu alaikum, dear colleagues. I'm very happy to have 2 of the eminent professors with me on this panel discussion. So what things will be going, I will be moderating this session, and 10 minutes before the end of the time, I will give a space for final remarks from both the panelists. If anybody wants to share slides or give a final talk about his thoughts about the panel, there will be, inshallah, 10 minutes at the end. I'm happy to have with me Professor Dr. Essam Alwani, my dear friend, and Professor of Otolaryngology at Alexandria University, and the President of the Egyptian Society of Otolaryngology, and Professor Dr. Muhammad Itribi, Professor of Immunology and Allergy, and the CEO of the Egyptian Society of Allergy and immunotherapy. We will start the session. Allergic rhinitis is an inflammatory immunoglobulin E-mediated disease characterized by nasal congestion, rhinorrhea, sneezing, and nasal itching. Of course, it's very common. Approximately 15% of the population having this disease, with the most common age between 15 and 45 years. This is a big incidence, and it's one of the most common diseases. It affects the quality of life. It has a loss of work, and it causes a decrease of school attendance as well. And as there are many diagnostic testing and treatment options, that's why there is a considerable variations in the use of testing as well as treatments, and that's why the need for guidelines, and we'll go for from the start of the presentations till the recent guidelines. I will make a few remarks, 5 minutes, for the newest or the most recent area guidelines that come at the end of the last year. So my first question is about the clinical scenarios in general practice. Do you consider symptoms as a group of symptoms? What the characteristic symptoms for allergic rhinitis? I will go with this question for Professor Dr. Sami Alwan.
Okay. Thank you, Dr. Yasser. Of course, you have cardinal symptom of allergic rhinitis, well known: itching, sneezing, rhinorrhea, and blockage, nasal obstruction. It is not necessary that the patient have all these symptoms at the same time. We always divide the patient into runners, sneezers, and blockers. Some patients, the main the main complaint is sneezing. Others are the main complaint is nasal blockage. And you should have more than one symptom. Water rhinorrhea is one of the important symptoms, bilateral water rhinorrhea, because it is not present in too many diseases, only in early case of viral rhinitis, and of course the unilateral cases of CSF rhinorrhea. So bilateral water rhinorrhea is a good is an important symptom that we should ask about it. Also the ocular, don't just concentrate on the nose, ask about the ocular symptoms, because when you have the patient has ocular symptoms, then this is good indication that he has true allergic rhinitis, IgE-mediated allergic rhinitis. Okay, the main differential diagnosis when you see a patient with rhinitis is to categorize the patient. Is he truly allergic or he is non-allergic rhinitis? This is the main problem. And one of the clinical landmarks that help us to differentiate both is the presence of ocular symptoms, the presence of very strong family history. This more often than not will be truly allergic. And the age, young age, is if the disease starts in young age, the patient is truly allergic. So these are the symptoms that we can see in a patient with allergic rhinitis. Dr. Yasser?
Thank you, Dr. Sami. So it's very important to acknowledge the history taking and physical examinations that should be consistent to allergic rhinitis, and there is a recommendation that the clinician should make the symptoms of running nose, itching nose, sneezing, or nasal congestion one or more at least of these symptoms. And of course, there are much more symptoms. These are the symptoms and signs of allergic rhinitis. For Professor Dr. Muhammad Atribi, do you consider classification by the type of history taking, classification of the disease?
Yes, the classification of the time, the history, the allergic rhinitis may be annual or seasonal. Maybe a common of the other allergic symptom or signs, at the itching, sneezing, as you say, and maybe due to annual all the year and seasonal prior to the allergic rhinitis, maybe sneezing and by pollen, mites, or other change environment for weather.
So, as Dr. Mohammed Etribi considered, it's very important to categorize the allergic rhinitis, whether perennial, seasonal, and of course it can be classified according to the this way, and it should be also classified according to the frequency of symptoms. Is this mild or moderate to severe allergic rhinitis? And this will give us to the standard classifications now according to the frequency of the and severity of symptoms and the persistence of the condition, because all the guidelines are dependent on different types. So we have mild allergic rhinitis, which can be persistent or intermittent. At the same time, we would have also moderate to severe, intermittent, or persistent allergic rhinitis. 4 categories. So the question for Professor Dr. Sami Alwani, is there a local specific clinical findings suggest for allergic rhinitis? How common do you see the face, the eye, and other stigmata? Are they helpful for diagnosis of allergic or for this very common disease?
Yes. About the, the signs of allergic rhinitis, you have external signs, the facial signs, and the nasal signs. In many cases, you can diagnose the patient with allergic rhinitis just from his face. The shiners, the blue coloration around the ear, the open mouth, what we call allergic gap, and the supra-tip crease, especially in children from itching of the tip of the nose. Especially the shiners are a very good indication of nasal problem. So external signs are important, and I believe that allergic rhinitis, one of the diseases you can spot diagnose it by inspection, just for inspection. Inside the nose, the classic finding is the pale edematous nasal mucosa, plus minus nasal polyps sometimes. They are not necessarily present, but the pale blue edematous nasal mucosa is the most important. If you try with the endoscope, if you touch the nasal mucosa, the patient may sneeze and something like that. So these are the signs of allergic rhinitis. We should put in consideration the external signs and the nasal signs.
But the main diagnosis, is it depending on the symptoms or combination of symptoms and signs?
Yeah, usually symptoms are enough. In fact, you can diagnose by symptom. In fact, it's very easy to diagnose allergic rhinitis. But what is not easy is to differentiate it between allergic rhinitis and non-allergic rhinitis. This is the main problem. But the diagnosis of what we call allergic rhinitis and allergic-like rhinitis is very easy from the symptoms. There's no, and as I can see in the picture, you have the shiners, supra-tip crease, and the open mouth.
Yeah, the transverse nasal crease, allergic salute. At the nose, there is the pale inferior, as you say, the allergic conjunctivitis.
And the ocular symptom, the ocular conjunctivitis.
Yes, yes. So, what are important questions in clinical history? This is a question for my dear Professor Dr. Etribi, to consider during evaluation of allergic rhinitis. What questions do you advise the physician to consider during evaluation of allergic rhinitis?
Yes, it is the best one is seasonal or annual, continuous or intermittent. Okay, and I search for about the major or a minor symptom at the history of atopic pruritus, orbital darkening, post-nasal drip, and other symptoms at the GERD and other common diagnosis for allergic rhinitis.
Okay, so this is the timing of symptoms to recognize perennial from seasonal, the impact of symptoms to differentiate between mild and moderate to severe, and the frequency of symptoms, that triggers, and whether there's a comorbidity like asthma and eczema, and of course the medication currently used or previously used. These are important questions in clinical history. And this is a question for both of you, actually. For Professor Dr. Essam Alwani, when do you perform or refer for allergy testing? And this will be also needed to be answered from Professor Etribi.
Yes,
okay.
According to our practice and the guidelines,
Yes.
diagnosis of allergic rhinitis is primary clinical. And so we should start, when we diagnose a case of allergic rhinitis, we start with pharmacotherapy. If the patient does not respond to pharmacotherapy, then I have to check the compliance of the patient, revise the therapy, revise the diagnosis. And if I am sure that the diagnosis is correct, and the patient is compliant, but is not responding, and there are no environmental factors interfering with my treatment, then I'll consider immunotherapy as a second line of treatment. These are the guidelines are saying that.
We are asking about testing, not the immunotherapy now.
No, I'm not testing. No, there is no way. If I am sending him to do the allergy testing after pharmacotherapy, then I am intending that if he's positive, I will refer to for immunotherapy. So it is the second step, not in the first line. Okay. Start with pharmacotherapy.
For resistant or severe symptoms, you don't start with testing.
No. That is against the no. This
Even if the patient have previous treatment for his condition, because usually we are, of course, we are having a participant from every level, but we sometimes work at a tertiary referral. So you have patients who have previously a long treatment with, have been treated for a long time for allergy. So.
But I have to revise the therapy. If you have this is very as a common experience that the patient will be would have been receiving pharmacotherapy from other doctor before. I have to check what did he take, everything, and if he is, I'm sure that he got every good pharmacotherapy, not necessarily from my prescription. Then I can send for allergy testing.
Okay, so the same question for you, Professor. When do you perform and interpret a patient with allergic rhinitis for specific immunoglobulin E testing, whether skin, of course, this is a standard, or do you perform also a blood allergy testing or not?
Yes, as my professor, Dr. Alwani, say, the immunotherapy is the third step, not first step. The pharmacotherapy is the first step, and the prevention is the second. And if you reach to the poor response of pharmacotherapy or difficult allergy, provide or an acceptable adverse side effect for medications or coexisting allergic rhinitis and asthma, is a good candidate for skin test. Or I hope prevention of the asthma in children. If you start the immunotherapy or scan early in children, I can stop proceeding to asthma. In general, the 80% patient of allergic rhinitis on the long run can lead to allergic asthma. If you start immunotherapy early, I can stop prevention of asthma in children. There to avoid long-term pharmacotherapy. The allergic rhinitis is a chronic disease. Maybe take pharmacotherapy for a long time. The patient desire to avoid long-term pharmacotherapy. In general, immunotherapy work the best with the patient with allergic rhinitis. Is a very, very good candidate, and maybe if you accompanied by allergic asthma.
So both of you agreed that first you do a medical therapy, but do you have like a time framework for this primary treatment for allergic rhinitis? So how long do you go for medical therapy before thinking in performing skin test or allergy testing?
if the patient have many signs and symptoms for allergic rhinitis pure, I can start immunotherapy after 3 months from pharmacotherapy.
Okay, so this agree with the American guidelines, the most recent of them, that it recommends doing or asking or ordering for skin tests in patients with diagnosis who is not responding to break treatment, or when the diagnosis is uncertain, or the knowledge of the specific cause of allergens is needed to start therapy. So, of course, this is important, and I will skip this.
I can add
Yes.
for this one. If the patient difficult to control symptom by pharmacotherapy,
Yes,
I can start the immunotherapy at this point.
Okay. So I will. There is the recommendation. There is no rule for imaging in allergic rhinitis. So the clinician should not perform nasal imaging in patients presenting with symptoms consistent with diagnosis of allergic rhinitis. The question, and this also, I think, it's a very important question. So I will ask both of you. Do you consider counseling about avoidance in details during patient management? So, and what much time do you spend with the patient? Because, of course, allergy avoidance is the most important and successful treatment of allergic rhinitis. So, do you consider spending time with the patient with counseling about the causative or igniting allergens for his condition?
Okay. Yes, I consider that, and I spend some good time with the patient asking about his home and his workspace and so on. You know, about this environmental control, it is controversial. You will see that in some guidelines they are putting it as a recommendation, in other guidelines they are putting, maybe the most recent guidelines is putting environmental control as an option only. But I think that we should, yes, we should talk with the patient about his environment, and logically avoidance of the allergens is a very good way to stop allergy. So I consider counseling.
Okay. What about you, Professor Etchebi? Do you consider counseling about avoidance?
Yeah, the first step for treatment of allergic rhinitis or allergic disease, the common is avoiding for trigger factors, the common pollens or mites or another. But I can start or I can't avoiding. You start the immunotherapy. I can start the immunotherapy at this point. Avoidance and start immunotherapy as a concomitant at the same time is very successful.
Do you recommend for the patients using some sprays for the mites, or some machines for cleaning the ear, the environment around? There are some of machines like air condition that will filtering, or air filtering machines for patients with allergy or asthma.
Yeah, it is very painful.
Do you use them? Yes.
Yes, I use the clean the filter for air condition and the other, and avoid everything trigger factors, other smoker and other factors, other trigger factors.
Okay, so as Professor Alwani said, it's put as an option. It may advise avoidance of non-allergen. Of course, I agree with Professor Dr. Alwani that and Dr. Etchebi that we should actually, I think this should be turned into recommendation. And by the way, do you advise removal of pets for patients who have beds at their home, or you leave it for the testing? Dr. Sami, do you
No, you have to ask about it, not as a routine. And I believe this point exactly is the main reason that they put, some guidelines put environmental control as an option, not as a recommendation, the pets. Okay, because, you know, abroad they are considering the pets very, so I don't, not routinely, but I advise the patient, of course, if you feel that your cat is making you worse, if you have birds, try to avoid them.
Yeah, but sometimes the patient may not notice, and sometimes,
yes,
the yeah, this is the question. You are not routinely asking for removal of bits?
No.
Yes. And what about you, Dr. Trivi, about bits?
It's very important to remove the pet and avoid the cat and the other trigger factor as a chemical agent, who's the dust mite, is very, very important. Yes. Helping to therapy for this reason, and maybe add immunotherapy or not.
Yeah. Although the guidelines and the bits are not very common in our society, but I usually tend to ask the patient also to get rid of the bits. And actually, we are trying to make a processing of some kind of brochure at the outpatient clinic to ask the patient ways to minimize allergy, whether house dust mites, pollens, or bed dander. So we'll go for the comorbidity, and this question for Dr. Muhammad Itribi. Is it important for ask for comorbidity, and why it's important?
Yes, comorbidity. You say that for allergic rhinitis, the environment, all the environment may be clean as a filter of air condition and the bed and the other, and this is decrease the comorbidity and treatment to the allergic asthma or atopic dermatitis or atopy. If patients have atopy or other disease as the allergic asthma, it is very, very important to decrease morbidity and help management for allergic rhinitis.
Of course.
And maybe the very, very important to select the, if start immunotherapy, the right immunotherapy.
So you advise immunotherapy if you have a comorbidity like asthma and allergic rhinitis?
Yes.
Okay. So of course, chronic morbidity is the guideline said that the clinician should assess patient with clinical diagnosis of allergic rhinitis and documents of presence of associated morbidity like asthma, atopic dermatitis, and actually these are important for different ways because allergy is a risk factor for subsequent asthma development. Patients with the concept of the United Airway Disease, there 50% of patients with asthma have allergic rhinitis, and about 30% of patients with allergic rhinitis have asthma. And of course, the importance of accumulation of drugs. So because patients may receive corticosteroid for asthma, and then you add another load of treatment for him. We'll go for the pharmacotherapy, and of course, pharmacotherapy depends on many factors: patient's preference, age, prominent symptoms, symptom severity, efficacy and treatment, speed of onset of action of pharmacotherapeutic agents, the current treatment at the market, historic response for the patient, from the patient himself, effect on sleep, self-management, which is a new strategy in dealing with allergic rhinitis, and this is very important to consider also. So Of course, we have many treatments that will discuss rapidly. The local decongestant, oral antihistamines and decongestant, local antihistamines, oral and local steroids, leukotrienes, antagonists, and the combination therapy and immunotherapy. So the question is for intranasal steroids for Professor Dr. Sam Alwani. When do you use intranasal steroids? How long do you use? And what kind of intranasal steroid you choose if you prefer? And do you use it at BRN or insist on doing it on a regular basis?
Okay. Nasal steroids are cornerstones of treatment of allergic rhinitis. They are the basic treatment, and the recent area recommendation even advised that you use nasal steroids even for mild cases of allergic rhinitis. So it is the cornerstone. We have to use that, but we should know that the patient should know how to use the spray, and he should know that nasal steroids takes time to get its effect, and the patient feel the benefit. They are different than nasal drops, the decongest nasal drops. So I am using nasal steroid almost in all cases, as a monotherapy, if the condition is mild or maybe moderate. For more severe case, I'll use combination therapy, of course, including the nasal steroids, of course.
So
and
you don't
important
use
thing
it
about
as a VRN at all?
no.
You don't use it at VRN, at the required,
No, I'm taking, the patient should know that regular use of nasal steroids is a must to get effect.
For how long? For how long? Do you
Okay.
Yes.
As needed, but this the interpretation of the word as needed should be accurate. As needed, that it doesn't mean that when I feel stuffy, then I use 2 or 3 puffs and I stop again. As need mean that I can use for a few weeks, for 1, 2 months, 3 months, and when I feel okay, I can stop. But if I lose it, I have to use it regular for some time, weeks,
So,
for example.
So you don't tell the patient that you will use it forever, or you keep him on follow-up?
Whatever will be depressing for the patient, I'll tell him take it for 2 or 3 months, and I have to check back with me, and don't stop it before informing me. Okay? But I don't like to say to the patient that you should use it for whole life. This is very depressing for the patient. Yeah. But the important thing, as Dr. Yasser, I told you that the patient should use it regular. If he wants to use it, it should be regular. Otherwise, it will have no effect.
So this was the question. So the recommendation is to use it prior to the season and seasonal allergic rhinitis, using regularly for long periods, and it has been recognized that intranasal steroid used BRN is not effective as a continuous use. And there are, as you mentioned, the use of topical steroids is carried the strong recommendation in all guidelines from the start. So whenever you face as a physician a case of allergic rhinitis, your first choice would be the topical steroids. And of course, as much as the guidelines, there are nasal steroids are considered as the most effective first-line treatment for patients suffering from allergic rhinitis with moderate to severe and persistent symptoms. And it actually, it can be used in other forms of rhinitis too. So whatever kind of rhinitis, allergy or non-allergic rhinitis, it would be helpful. Professor Muhammad Akribi, oral antihistamines. This is also another important problem. When to use type and dosage combination therapy between oral antihistamines and steroids, whether local or systemic, and the duration of treatment. What is the role of oral antihistamines in your management way for allergic rhinitis?
Oral antihistamine is the safe to use for a long time. Is the first, and all the allergic rhinitis or allergic symptoms, maybe skin or other, use antihistaminic. Antihistaminic dose may be doubling or tripling for some disease. Maybe if allergic rhinitis and atopic dermatitis, maybe use 3 tablets per day or 4 tablets per day. The advice for the use antihistaminic with the same active ingredient, I can increase the dose from the same active ingredient, no different antihistaminic first or second or third or different for the same patient. Can use the antihistaminic,
clear for me.
the active, the same molecule by dose.
Or combined types of oral antihistamines.
The best is not combination.
Yes. So if you increase the dose, but not use a combination of antihistamines.
Yeah.
Yes. Okay.
And duration for a long time, not definite.
How long can you keep the patients on oral antihistamines?
For many months, there is no limitation. Just relieve symptoms or sign. I can increase the dose from the same molecules.
So if you have patient with isolated allergic rhinitis, how long do you keep the patient on antihistamines? The same way if you have skin allergy, eczema, or neurodermatitis or other kinds of allergic response, or for allergic rhinitis, do you use this the same way? Do you use oral antihistamines in allergic rhinitis the same way you do it with skin allergy?
Yes.
Okay. What do you think, Professor Dr. Sam Alwani, about the use of oral antihistamine?
Oral antihistamine has the advantage of being fast acting, and they are primarily useful if the patient is primary complaint is sneezing and rhinorrhea. They can stop it even without the corticosteroids. So if the patient, my usual practice, in fact, although it is not evidence-based so far, is that I combine topical steroid with a second generation antihistamine, and the dose that we give in ENT usually is a small dose, just 1 tablet per day. Recently, I replaced that with the topical, with the use of combination steroids and nasal antihistamines as one product. Yes, commonly that I use. One word that I'd like to say about the oral antihistamine, there is the problem of tachyphylaxis. If we use the same antihistamine for several months, the patient will not be responding well to it. So if the patient needs to use the oral antihistamines for several months, this is good practice to switch from one group to the other to avoid the problem of tachyphylaxis.
So there is a conflict between the real practice and the...
yes. At this point, I don't know how to resolve it. I don't know why.
Actually, I use also this combination therapy between a local corticosteroid and oral antihistamines, but I tended to stop the oral antihistamines shortly before continuing with the local corticosteroid. Of course, the local antihistamines are recently pushed in the market and in the guidelines, so we have to consider also its use. The intranasal antihistamines is a new in our market here, and of course as a combination. But intranasal antihistamines has been found for many years in the market, but it didn't meet like a general acceptance for use before. But now the recent guidelines are considering it as very potent in management of allergic rhinitis. So for this short period of time, have you used it for the patients with allergic rhinitis, Dr. Sami?
The intranasal antihistamines?
The intranasal antihistamines,
I use it as a combination with intranasal steroids, and I give one puff, one spray in each nostril, morning and evening. So the total of 4 sprays per day.
From your practice, did you find it's more efficient than local corticosteroid alone?
I didn't use it for a long time, but maybe 2 or 3 months. But I think it is working. It is working.
Okay.
But you know that the intranasal steroids in the combination is the propionate, the fluticasone propionate, not the furoate, which is less effective than the furoate. Okay.
So, have you used this combination, Professor Tribi, of intranasal antihistamines or intranasal antihistamines alone?
Yeah, as my professor, Dr. Alwani, say, once per day for short time, antihistaminic combination with intranasal corticosteroid.
Okay, so it was before an option. Actually, this is intranasal antihistamine. It was an option in the American Academy of Otolaryngology guidelines, but in the area in 2019, it has jumped with the combination therapy to a very high level of evidence. For Professor Dr. Tribi, when do you use oral leukotriene receptor antagonist in patients with allergic rhinitis? And do you prefer certain type? Do you use a combination therapy of these? What are the duration of treatment for oral leukotriene receptor antagonists?
Anti-leukotrienes can combination with antihistaminic at the same time, and used with allergic rhinitis and allergic asthma. It is very, very effective. And the different dose, 4 milligram till 2 years for age, and more than from 2 years to 10 years can use 5 milligram, and after that can use 10 milligram per day. At the same time, at the evening with the antihistaminic is very painful.
How long do you use the oral?
I use for 3 months maximum, or maybe extended to 6 months.
Because we as for allergic rhinitis, there is a recommendation against its use in allergic rhinitis alone, but if patients has allergic rhinitis and asthma, it has been recommended or considered as an option. So do you use it for allergic rhinitis alone or allergic rhinitis with asthma?
Allergic rhinitis with asthma.
With asthma. So Dr. Sami, do you use anti-leukotrienes for allergic rhinitis alone or allergic rhinitis with asthma?
No, it is only of this asthma. And usually the chest physician is prescribing it. So, but for allergic rhinitis alone, no. That has no effect on the. So, but if it's asthma, then I can use it.
So the recommendation against is clear from the panelists against the use of anti-leukotrienes in management of allergic rhinitis. The combination therapy, this was an option, and I see that all the panelists are using the combination therapy for treatment, and actually this protocol is considered using this is the last protocol of the American Academy about using a monotherapy first, and then if there is inadequate control of symptoms, use or add a combination therapy. So at the start of treatment, Dr. Sam, do you follow this? Do you use a monotherapy first, or you jump to the second for combination therapy? This is very important.
Before that, you are referral. Okay, we
yes.
don't. So I usually start with the combination, unless the patient is very mild case. Yeah. But sometimes, if the patient is primary, which is very infrequent, is primary even symptoms, just sneezing in the morning, then I just give him antihistamine at the bedtime. Yeah. but usually it's a combination therapy.
Although
it is not evidence-based, as you said before. I know that is not evidence-based so far.
Okay.
But, I believe
Dr. Etrebi, do you use a combination therapy from the start, or start?
Yes, the combination loop trials and the histaminic give result at the corticosteroid-like action. Very good result.
Okay, so of course this was a recommendation, but it seemed that it didn't meet acceptance, and actually the acceptance of the patient also should be considered, as we will go for a slide. So the combination therapy, now this is a slide I took it from my dear friend Dr. Essam Hamid. It is a combination for intranasal steroid and oral antihistamines, and also a combination of intranasal steroids and intranasal antihistamines. Both are recommendation, and this is considering the patient's preference. But the recommendation is not considering oral or intranasal antihistamines alone. So they combine the use of oral antihistamine with intranasal steroid. But the problem is with the ERA guidelines 2019, they say that the combination therapy is not better than intranasal steroids alone. Although it's a common practice worldwide. So I don't know, I think we need to consider this, and maybe we try to do some research about, of course it will depend on the visual instrument, which is immunotherapy. Using combination therapy or
الصوت مش واضح قوي دلوقتي اللي عندي، مش عارف.
لا الصوت قطع خالص.
مش كده؟ مش واضح الصوت.
دكتور وسام، الاورجنايزنج كمباني عندنا مشكله في الصوت. التكنيكال بيبل معانا لو سمحت.
هو غالبا النت فصلت عند دكتور ياسر، رجع.
لا ما كان ريكونكتنج، ما اعرفش ليه. فهو the role of immunotherapy, I will ask Dr. Sami first, what do you think about the role of immunotherapy in cases of allergic rhinitis, the indications, type and duration, follow-up and cause of failure.
لا هو بص، التايبس والديوريشن الحاجات دي حاسبها للدكتور محمد اكتب.
هو I know this is actually
شغلتي.
I want you to know your situation, because you know we discussed this with you and other, and I don't want to be beside anyone, but so you don't use immunotherapy as much. Yeah, this is my question. Do you use it or not use it?
Okay. The indication of immunotherapy بالنسبة لي هو لو failed pharmacotherapy, the diagnosis is through allergic rhinitis، أو لو كان عنده allergic asthma معاه برضه this patient أو other atopic comorbidities. هم دول العيانين اللي هم يعني كرايتيريا اللي تخلي الواحد بيحب الاميونوثيرابي، يعني يقدر يبعت عيان في الاميونوثيرابي. فيلد فارماكوثيرابي
you don't frequently
كل حاجه، او لو في الرجي اذر اتوبيك كوموربيديز بالذات لو كان عنده برونكيال ازمه، فده العيان اللي هو هيستفيد. بس كلها طبعا سكند لاين افتر يو هاف تو شود تراي pharmacotherapy and we should be sure that the patient is truly allergic. ودي برضو الدكتور محمد عتيبي يقدر هو عن طريق بقى الالرجي تيست وكده يقدر هو اللي بيحددها يعني. والباقي بقى هسيب للدكتور محمد عتيبي يرد على السؤال.
You don't advise for it in most of the time. This is my question.
لا هي لا مش يعني مش كتير قوي يعني، مش كتير يعني مش
Okay, so I will shift to
العيانين عشان يعدوا من الفلترز دي كلها بيكونوا قلوا شويه.
طيب دكتور اتربي, when do you use immunotherapy? What's your indications? What are causes of failure of immunotherapy?
Yes, the indication of immunotherapy, the third step, as my professor Alwani say, the pharmacotherapy, the third, and the prevention for allergen, the second, and the start to the immunotherapy, the failure of the pharmacotherapy or long-term used pharmacotherapy or to avoid the corticosteroid, and what can I say, the mites, as a mite, مثلا, cannot avoid the mites. The immunotherapy is very, very, very important as a step. But what the types of and durations, immunotherapy, two types in Egypt, sublingual and subcutaneous. The two form available. Follow-up by 3 months per patient. Why immunotherapy successful؟ برضه هتقول ان هو الفيلير ليه؟ success لو احنا استخدمنا right patient, right selected by lab and examination, also for start to prevention and pharmacotherapy, right allergen pure and standardized. واحنا الحقيقه في مصر لغايه النهارده ما فيش, there's no pure and standardized. All the immunotherapy is imported from a state or other country to use in Egypt. Right dose is very important. Number of antigen per dose is now available in Egypt. Right duration at least 2 years to 5 years, from 2 years to 5 years. Right setup mixing, كل دي في خطوات كتيره للسكسسفول. ان انا استخدمه, ان انا استخدم بيور انجن, ان انا استخدم ستاندرايزد, ان انا استخدم رايت ميكسنج, ان انا فيه بالنسبه للكومباتبل وريسكي ونون كومباتبل في خلط الانجن, وده مهم جدا جدا. نشوف ده الحاجات اللي بتخلي الاميونوثيرابي سكسس. والحقيقه استخدام الاكستراكت ان ايجيبت, اللوكال اكستراكت ان ايجيبت give the bad result for immunotherapy in Egypt. Because of the very lack of good correlation between allergen testing and resulting and the clinical history, المريض لازم يبقى allergic فعلا. inadequate dosing, ان انا استخدم low dose treatment او mixing مش صح, ان انا اعمل missing للكلينيكال ريليفنت allergen serum. البور كومبلاينس في السكيدول ده مهم جدا. الفولو اب للبيشنت مهم جدا جدا. احنا بنعدل في السكيدول دودنج للبيشنت من زياره لزياره, كل 3 شهور بيزور الطبيب وبنعدل في الدوز. الحقيقه ممكن من يعني بنبتديها من بير تو داي, day other day and per week and then per 10 days and dose per 15 days and till the 1 month, dose per month. It's very efficient and very effective. الهاي ليفل of the allergen is the environment, ان احنا برضه significance نستخدم حاجات الانتمايتس and other prevention for or avoid to allergen.
So this is actually the clinician recommendation for use for patients who are symptoms not controlled with the pharmacotherapy. And actually this has some details because it's about, of course, moderate and severe allergic rhinitis symptoms, that the symptoms are recurrent if you stop any of the treatments for him for short time. So what is the role of surgery there? If there is a deviate septum, this for the nasal blockage, not for the allergy. Although some of the patients may benefit from surgery of the tablet, sometimes we notice a reduction of the symptoms, at least for a period of time. Of course, there is a treatment of complications and nasal polyps associated. This is an option of treatment. So I will jump to the for a few minutes about the recent guidelines. It has been noticed that these guidelines that we are using, the patients are poorly adherent to it. Even if you are a doctor and using treatment allergic rhinitis, the adherence to the guidelines, if you ask the patient to take oral antihistamines or even a local corticosteroid for several months, very poor compliance of the patients to treatment. Very few patients are complying. Most of patients use on-demand treatment, and the vast majority of patients don't follow guidelines. And actually, this pushed the area to consider another studies depending on contact with the patient through the mobile applications. This is called mask study, and it has been done in 22 countries in Europe, and through the a strong study called a chamber study for use of the speed of action of the treatment. This push to what's called real world evidence. The guidelines that we were discussing for the last hour, they are evidence-based, but the patients are not following them. This is real world evidence. According to two studies, one from Europe, this is called mask studies, and other from the United States, that our patients, when they are controlled, they stop treatment or remain with single treatment. So you write your prescription according to evidence or your experience, and the patient are not listening. So the grading recommendation, this actual recommendation is applied not only in allergic rhinitis, it's applied in also in rhinosinusitis and other kinds of diseases. This is grading of recommendation, assessment, development, and evaluation. This grading system involves the patients with us in treatment, and using all kinds of studies, whether controlled randomized studies down to case reports, using, as I said, the masks, chamber studies. And actually, they got us very disturbing, as I see, new guidelines that keep you in close contact of the patient. So they bought an application on the mobile phones with your patients, and you ask him how do you feel, and according to the visual analog score, you evaluate the patient. These are the new or the recent guidelines. I know we still have a few minutes, but I want to ask Dr. Osama that because he took 5 minutes from mine, to extend a little bit. So the new guidelines are depending on the visual analog score. And it is stated that if visual analog score is very low, use any treatment. And whatever, oral antihistamine, oral intrinsic corticosteroid, whatever. If it is high visual analog score, if it's intermittent, use any treatment. If persistent, use intranasal steroid alone or in combination with a local antihistamine, and they reassess after a few days. And if the symptoms are still there, then consider immunotherapy. So this are the recent guidelines. This is like getting into individualized treatment, because this actually I don't know how we will comply with these methods. I was yesterday discussing with our students with the new EBUS 2020 and the self-care is considered appropriate. So I have two last questions. What do you do if you no responsive treatment for Dr. Sam Alwani? If you have patients is not, what do you do?
To my treatment, which means pharmacotherapy, I think. Okay.
Yes.
If the patient is not controlled by the primary treatment, I have to discuss first with him the patient for his compliance, regarding taking the medicine and environmental factors. Is working in the same environment, is beds, something like that, carpets in the bedroom and something like that. So if the patient is taking a pharmacotherapy and is compliant and everything, then everything fails, then I have to refer him for the allergist.
Do you consider interchange of drugs?
Yeah. What I do practically, if he doesn't respond in the first at the first treatment, I'll add some corticosteroids, oral. Usually, if he doesn't improve after corticosteroid, even low dose corticosteroid, I don't give him the 40 milligrams. This is too high dose. I consider it high dose for this patient. I just give maybe 10 milligrams per day. If he doesn't improve after that, then I'll think the advice of an allergist, but not before that. But these are very few patients. Most of them respond.
Thank you.
Most of them respond to treatment. Okay. Dr. Yasser, اتفضل. مش عارفه دكتور ياسر معانا ولا؟
دكتور ياسر غالبا ديسكونكتد
تاني. طيب هنقدر. طب دكتور محمد تحب تضيف حاجه؟ طيب دكتور ياسر.
بالنسبه للإيفالويشن for patient if you have failure treatment for immunotherapy.
دكتور محمد, this is a question for you.
دكتور ياسر
دكتور ياسر انت عندك مشكله في الكونكشن
بس مش عارف. Do you hear me؟
بس هي السكرين باينه عموما يعني.
دكتور ياسر
اتفضل دكتور ياسر.
دكتور ياسر
I was asking about yes. Oh my God. Okay. This is our last question.
Yes. اتفضل.
هو مبينه دكتور ياسر الرول اوف برايمري كير. دكتور محمد حب يجاوبها يعني.
الدكتور علواني طبعا ده هو البرايمري كير فيزيشن ان مانجمنت اوف الرجيك راينايتس. ده من الحاجات الدايجنوز صح والتريتمنت. الفارماكوثيرابي بنبدا بالفارماكوثيرابي والافايدنس. Pharmacotherapy, the nasal steroid can add leukotrienes for antihistaminic and other.
Okay.
والدكتور ياسر ظهر عنده مشكله في الكونكشنز بتاعته. طيب يعني if you دكتور ياسر.
ايوه انا معاك.
انت غالبا عندك مشكله في الكونكشنز يا دكتور ياسر.
ممكن يوقف الكاميرا كده، يجرب وقف الكاميرا.
دكتور ياسر معانا؟
ايوه معاك انا. I hear you.
طيب لانه كمان احنا دكتور ياسر we are about to finish the 1 hour, so if you allow me انا عندنا شويه questions جايه من الاودينس. If you allow me to do that دكتور دكاترتنا الاعزاء. اولا thank you very much for the discussion. Was a really nice, rich discussion. Now the first question is asking about, do you recommend priming while giving the local intranasal steroids? دكتور سامي والدكتور محمد عتربي.
هو قصده برايمنج يعني للبوتل نفسها ان نهزها يعني كده؟
I think الدكتور محمد عتربي ان the allergy يعني they have different definition of priming. دكتور محمد ايه رايك؟
تمام، لكن هو الحقيقه في حاجه مهمه جدا is the very important to use the nasal irrigation for any nasal steroid. Nasal irrigation is very important.
You mean before you use the steroid?
Yes. Nasal irrigation by alkaline or Vidomir or other agent is very important.
دكتور سامي, do you agree on that?
هو استخدام النزل irrigation is one of the options in allergic rhinitis, but يعني بالنسبه لي هقول انا بقوله يعني بعمله، انا ما بستخدمهاش روتيني قوي، لكن لو العيان محتاج عنده كانوت كلين ان اساسا عنده لو هو بيور allergic rhinitis. انما لو كان عاوز هيستخدم النزل irrigations ما يستخدمهاش immediately، يعني ما يعملش irrigation and على طول يعني then immediately spray the nose. لازم يبقى في وقت ما بينهم علشان تضمن ان السبراي يجي على النزل ميكوز على التارجت اريا، يعني ده one of the common mistakes ان العيان بيغسل مناخيره and then he use immediately the spray، والسبراي المناخير لسه فيها wet فيها solution and it doesn't give effect يعني. لكن يعني not on every patient but it is one of the options of course in the guidelines.
كان في سؤال تاني يعني sounds strange but انا هسأله.
بس انا عاوز اقول حاجه دكتور اسامه، اصل ساعات مكتوب في البروشورز ان البرايمنج بتاع البوتل انك ترجعها كده قبل كل يوز، يعني يمكن هو قصده على كده في الاغلب يعني.
هو البرايمنج يا دكتور سامي في الالرجي ان هو بيعلى بالدوز، يعني gradually increasing the dose.
ما هي ذات هيزود الدوز يعني.
يعني انت تدي 1 puff and then you give 2 puffs or you give 1 puff daily once every side يعني to divide the dose and then increase the dose. So I haven't read this. I have no experience with this in the nasal steroids. The coming question is the doctor is asking, is there a role of surgery? أعتقد إن إحنا جاوبنا عليها. بعدين في سؤال تاني بيقول لك is allergic rhinitis life threatening؟ ويمكن عاوز يسأل يعني impact of the allergic rhinitis على يعني quality of life. فيعني بتهيألي حضراتكم جاوبتوا على السؤال ده في الأول إجابة كاملة يعني.
أنا بس كنت
سؤال تاني بيسأل. نعم اتفضل.
بالنسبة للسيرجري لازم يعني وات ايفر سيرجري هتتعمل للعيان لازم العيان يبقى فاهم very clearly إن this is not treatment of the allergic process. It is not treatment of allergic rhinitis. Otherwise هيتخانق مع الدكتور بعد العملية وإن هيلاقي.
I totally agree يا دكتور سامي. The consenting of the patient during doing surgery for the allergic rhinitis patient is very crucial. That the patient should understand why we are doing the surgery. So لأنه أنا يمكن أتفق مع الدكتور محمد عتربي and the golden standard for the treatment of allergy is actually the immunotherapy. This is the specific kind of treatment for allergy. إنما treatment is اللي هي الانتايستامين والنيزال steroids and these are all symptomatic treatment. وبالتالي الجراحة again لها certain indications. كان في سؤال بيتكلم على لو العيان عنده aspirin sensitivity والعيان ده محتاج ياخد aspirin for ischemic heart or for as a blood thinner. What do we do? What do we do? دكتور محمد عتربي, what do you think?
Can treatment by immunotherapy for 6 months and start aspirin after that.
Okay. Aspirin after sort of when I stop the treatment for a while.
بالنسبه للاسبرين
ان هو الاسبرين ده هو سنسيتايزيشن بس مش هو زي بتاع الالرجيك راينايتس، يعني هو اسبرين
فور اسبرين هايبر سنسيتيفيتي
الرجي فور اسبرين
فعشان كده بتعمل له اسبرين دي سنسيتايزيشن، ما عادش الدكتور محمد بيعمله او كده؟
بنعمله
هو عاوز اسبرين ديسنسيزيشن يعني.
يس اوكي.
وبعدين ياخد بعد كده الدراج. في سؤال تاني
بتاع الاميونوثيرابي يعني.
اوكي، في سؤال تاني بيسأل على الانتي هيستامين سبراي، نيزل انتي هيستامين. The use during pregnancy, is it recommended or not؟ دكتور ياسر ايه رايك؟
هو
نازل انتي هيستامين في البريجننسي.
هو اللوكال كورتيكوسترويد فيهم واحد تايب بي، ده used in pregnancy. لكن اللوكال انتي هيستامينز I am not aware of studies done to and I don't think there will be one.
The last guideline can you use antihistaminic or corticosteroid during the pregnancy? No forbidden.
يعني دكتور محمد the recommendation is use it without any problem.
Yeah.
دكتور سامي هل لك رأي مختلف؟
And also there is no class B and class A in pregnancy for asthmatic treatment.
they are used يعني for asthmatic. هو حقيقي البودوسينايد بس اللي هو الاف دي اي ابروفد البودوسينايد، وهو ابروفد از انهيلر مش از نيزل سبراي.
لا احنا بنتكلم عن انتي هيستامين يا دكتور سامي.
اي نو مفيش ستادي دلوقتي، بس اي دونت ثينك ان هيبقى في اي كونترا انديكيشن، لان ايفن الجاينيكولوجيست بيستخدموا الانتي هيستامينز للعيان اللي عندهم بريجننت فيميل ويز برورايتس.
يس يو ار ابسولوتلي رايت دكتور سامي، انه بيستخدموا الاورال انتي هيستامين. if you are using the oral antihistamine then you can use the nasal antihistamine.
بالظبط كده.
السؤال الاخير عندنا بيتكلموا على البيولوجيكال ميديسن، البيولوجيكال بقى اللي هم الانتي اي جي اي and so on. When to use them, and we know that they can be used, or there is some indication for the asthma, but when do you يعني advise the patient to start on the biological medicine? دكتور محمد يمكن elaborate more on this. دكتور محمد العتربي ايه رايك؟ امتى نستخدم البيولوجيكال في عيانين allergic rhinitis؟
In severe cases, not responding.
What do you mean by severe cases؟ لا برضه it's اريا يعني فيك شويه. يعني هل اللي عنده 10 فيجوال اناليز سكور استخدم له؟
هو حضرتك البيولوجيك تريتمنت now are being used in rhinosinusitis.
ايوه ديفرنت.
لكن الالرجيك راينايتس
بنتكلم على الالرجيك
راينايتس have not been mentioned.
لا مش موجوده خالص لسه في
الجايد لاينز، يعني مش موجوده في الجايد لاينز خالص، لا في الاريا ولا في الامريكان جايد لاينز في علاج الالرجيك راينايتس.
هم بيتكلموا عن البويد راينوسينوسايتس بس، البيولوجيكس في البويد راينوسينوسايتس نوت فور الالرجيك راينايتس مش موجوده فيه.
With the combination.
It's very expensive.
Yes, I know.
دكتور محمد
not using the multiple bacteria in allergic asthma or allergic rhinitis with atopic dermatitis, the good result في الeczema and
طبعا في الازمه اتورث، لكن الالرجيك راينايتس لوحده بيور كده، الالرجيك راينايتس لوحده لسه لكن طبعا في الازمه
لان هو الدكتور ياسر طرح سؤال if you are using everything and patient is not satisfied then at that time نعتبر ده دكتور محمد هو السيفير. يعني you have been treating the allergic rhinitis now for month، بقالك 6 شهور 10 شهور بتعالجه and he is not satisfied وبيعمل environmental control و is compliant بالنسبه للعلاج، كل حاجه اوكي and there is no response.
biological treatment anti free IgE give rapid response.
ما هو ده biological، يعني احنا بنتكلم عن ممكن ادي biological.
Yes immunotherapy anti-target anti-fixed IgE give rapid result for allergic rhinitis accompanied by the atopic dermatitis or allergic asthma.
لان هو السؤال الثاني السؤال اللي هيجي بعد كده I'm sure you are expecting this question for how long we're going to give it، لانه احنا ما عندناش في البيولوجيكال medicines اللي هم بيستخدموا في other indications ما عندناش duration. As you know it's very expensive. فلو انت هتبدا تدي العيان عنده allergic rhinitis تدوا له قد ايه؟
By my experience I start biological treatment for 2 or 3 months only and start immunotherapy with them at the same time.
Okay.
give result, give rapid result in the first and second months, and immunotherapy continue.
Okay. في سؤال بيقول لك is there any complications for the intranasal steroids دكتور سامي؟
لا سو فار ما فيش غير السنسوري اتريبيوتس بتاعتها. سو فار السنسوري اتريبيوتس اللي هي طعمها وحش وإيريتنت وحاجات زي كده، لكن
يعني
انما لا ده مش كومبليكيشن، لكن ما فيش ريبورتد كومبليكيشن يعني لغايه دلوقتي ما شفناش حالات اتروفيك راينايتس فولوينج انترنازل.
دكتور ياسر have you seen any complications؟
the dry nose only. وفي patients يعني عندهم concept بعضهم not using any local treatment، وفي patients refusing any local corticosteroid يعني
لا بس this is not complications دكتور ياسر. ده
هو dry nose. I say dry nose and the nose bleeds sometimes. Nose bleeds and dry nose.
في سؤال سيرجيكال جاي بيقول what is your opinion about posterior neurectomy for severe cases unresponsive to treatment؟ يعني عاوز يعمل فيدا نيوركتومي. دكتور سامي انا عارف ان انت ليك اوبينيون في الحكايه دي.
لا هو كل فيدا نيوركتومي وبوستيريور نيزل نيرف نيوركتومي وجربنا البوتكس ابلكيشن كلها temporary. After 6 months everything returns back.
So
even after video neurectomy.
You don't recommend?
No, I don't recommend خالص، لان دي يعني even after video neurectomy رجعت النزل ميكوزا الرجيك بعد 6 months.
اوكي.
عشان وده حتى هم بطلوا يعملوا فيديو، قالوا يعملوا عشان اللي هو بوستيريور نيزل نيرف بس لوحده، وعملنا البوتكس افضل ما بيقعدش اكتر 2 و 3 months.
في ايفيدنس يا دكتور اسامه ان في لوكال اميونوجلوبولين اي داخل النيزل ميكوزا، يعني في لوكال رياكشن،
لوكال الرجيك راينايتس، اللوكال الرجيك.
طيب احنا كده الحقيقه these are all the old questions and the comments we have received. أنا by the end now قبل يعني before we close عايز أسأل الدكاترة زمايلنا الأساتذة الأفاضل السؤال اللي الدكتور علي سأله at the end of the session. إحنا in Egypt they already opened the restrictions على ال COVID-19. The country now is opening everywhere socially and economically. فاعتقد ان احنا كجراحين we need also to go back and start working. فدكتور سامي are you going to go back to normal elective cases or not? It's a very simple question.
Some elective cases after PCR يعني مثلا
انا لسه هتكلم عن هنعمل ايه. السؤال الاولاني first question are you willing to go for the elective cases now ولا because we are not sure whether we are at the peak or we passed the peak or we are expecting another peak. We are not يعني medically speaking we are not sure, you know that. So are you willing to go to the elective cases now or not?
لا يعني very limited يعني very limited maybe.
دكتور ياسر
الحقيقه انا يعني ما بنامش بالليل.
انت ياسر
I don't sleep at night.
في المنصورة. بنتكلم على your official situation.
Yes, I don't sleep at night because of this situation. لأن يعني في strong responsibility. We will go for gradual reopening.
Okay.
First, we're confined to the urgent cases. Now we are going very slowly, graduating and observing.
Right. So
there is a problem with the testing. You cannot.
أنا جاي للسؤال الثاني يا دكتور ياسر.
Yes.
So last week we had 3 ما اعرفش حضراتكم did you attend or not?
Yes.
But we had 3 options. Yes. One from United Kingdom, from Manchester, Royal Infirmary, which is a big establishment in the northern England. The Dr. Penny said they are doing PCR 14 days before the operation and repeat 3 days before the operation.
Yes.
Dr. Adil Khattab, who is a counselor for the Higher Education Ministry, he advised doing chemical testing and the CT scan. Dr. Nasser Said, who is a preventive medicine specialist, said depend only on the clinical situation. النهارده سمعنا ليفربول دكتور اسلام قال 3 days is enough، والدكتور عصام من السعوديه the recommendations في السعوديه 3 days is enough and doing PCR. احنا بلدنا we will not be able to do PCR for every patient.
السيتي للاسف اسهل.
رايكم ايه؟ دكتور سامي علواني ستارت.
لا انا without PCR مش هيقدر I will not operate. يعني ده يعني next week انا عندي اوبريشن العيان عمل PCR.
Do you advise him to isolate بعد البي سي ار or not؟
I advise him.
دكتور ياسر.
الحقيقه يعني في اللوكاليتي عندنا السي تي اسهل، سي تي شيست يعني اسهل من البي سي ار. يعني the patient will find a great difficulty in getting PCR حتى على المستوى الرسمي. يعني العيانين اللي هم اللي في المستشفى ده عندنا مشكله ان المخالطين بتاع الحالات we are stopping doing testing for them. We get testing for who has symptoms sufficient to diagnose and not his surrounding. فاحنا عندنا مشكله دلوقتي، وده اللي مخلينا reopening very slow. عندنا سيتويشن وحالات وتراكمات غير عاديه.
مشكله في البي سي ار.
دكتور عتربي on the medical side انت ما بتعملش عمليات، بس حضرتك بتشوف العيان وبتعمل له الاميونوثيرابي، بتجيبه جلسات كم مره يعني repeatedly. what are you going to do؟ هتشوف العيانين من زي ما كنت بتشوفهم ولا في نظام مختلف ولا what do you advise؟
في نظام مختلف is the different situation. But I start the patient when use pharmacotherapy, give 2 shots from pneumococcal vaccine. It's very essential. It is most cases, or maybe 99 cases, it is prevented. It is mild to moderate, not severe. CT is sufficient, but the vaccine is a good, very good rule for prevention.
على الفاكسين هو anti streptococcus.
Yes.
You're talking about the secondary infection.
Yeah, I have many patients. The disease stopped proceeding to infected the lung or deteriorated by the lung. Just mild to moderate case.
Right. So you think the panelists أو يعني دكتور ياسر من منصورة في جامعة كبيرة، you think إن إحنا we will not depend on the PCR. However برضو لنا أصدقاء في دبي وأصدقائي في أمريكا في United States. They sure ask for the PCR.
Yes.
And they ask for 3 days. 3 days. لأن دكتور ياسر حقيقة.
If it's available, I will ask for it.
The risk is high.
Yes.
The risk is high for the patient and for the doctor.
Yes. If it is available, I will ask for every patient.
It's available, دكتور ياسر. No, it's available. The PCR is available. It's expensive, I know.
Yeah.
But it's available. وبعدين احنا بنعمل ما انا ما بقولش هنعمل ل 100,000 واحد في اليوم، احنا هنعمل للعيانين اللي داخلين جراحه.
ما احنا حضرتك عندنا المفروض يعني حتى في الوقت اللي احنا فيه ده عاملين حسابنا ان احنا نعمل 5 حالات في اليوم. يعني انت ده الكلام ده في النون اوبننج، يعني هنعمل 5 عيانين في اليوم.
ياسر the cost is high. The cost I'm not talking about the money cost. I'm talking about إذا ده دكتور إسلام النهارده قال لك إن mortality if you are not sure that is COVID وهو كان COVID carrier وعملت له عملية the mortality is 20%.
Yes.
20% is very high.
Yeah.
الحاجة الثانية are you ready to have infected doctors الهيلث كير وركرز اللي هو الفرونت لاين بتاعك يبقى انفكتد؟ هنا الكوست اعلى كتير جدا من الماني كوست. انا I think I go with Dr. Sami and I go with the international guidelines. ان احنا العيانين هيخشوا عمليات I think لازم يعملوا PCR.
We have a struggle with it. We are struggling for that, دكتور أسامة.
والله دكتور ياسر I know ان انت are struggling. I know ان a lot of places ما عندهمش تكاليف بس to protect the patient and to protect the doctors.
The hospital will not pay for this, and التأمين الصحي will not pay for it, and the patient in many times he cannot pay for it. So
عارف يا دكتور ياسر الاسبوع اللي فات دكتور بيني from Manchester showed us the PPE that she is using.
Yes, I know.
PPE اللي هم بيستخدموه غير اللي احنا عندنا خالص، حاجه ثانيه خالص. حاجه كلها الاير is under pressure by machine. يعني قضيه مختلفه، لان انت when you lose a front line doctor الحقيقه you cannot replace. فالحقيقه anyway مش عايزين نطول عليكم. الحقيقه was a very nice discussion. Thank you very much دكتور سامي، دكتور محمد، دكتور ياسر for moderating this session. I hope in all the attendees الحقيقه استفادوا من discussions، لان النهارده كان عندنا two common issues اللي هم الاوتايتس ميديا والديفيوجن والالرجيك رينايتس. بعيد عليكم تاني ان احنا ان شاء الله اللي حضروا معانا السيشنز هنبعت لهم electronic certificate يقدر يطبعها من على الكمبيوتر بتاعه. Those who attended the 3 waves, last week wave, this week wave، وان شاء الله next week wave. الاسبوع الجاي عندنا محاضره، عندنا بانل قائمه جدا على الريفلكس، and as you know reflux is important in DNT. وعندنا محاضره على the use of the antibiotics in the upper respiratory tract infections, namely acute otitis media, acute sinusitis, and tonsilopharyngitis. I hope ان احنا you join us next week. Thank you very much again. وهاف
اسمح لي يا دكتور اسامه اشكر الدكتور سامي والفرصه السعيده، والدكتور محمد اتربي على يعني تواجده، واعتذر ان النت قطع شويتين مرتين كده، لكن الحقيقه it was a fun and enjoyment and I hope it was a useful thing. شكرا يا دكتور اسامه. طبعا
على خير الساده الافاضل الاتنديز اللي على الزوم واللي على الفيسبوك، احنا نشكركم جدا على حضوركم ونشكركم على اسئلتكم. واجين احنا we are expecting any questions or any comments to improve، نحسن الماستر كلاس. لو عندكم topics معينه عايزين نتكلم فيها please share with us على السايت. شكرا والسلام عليكم.
مع السلامه.